the summary of drugs to treat upper respiratory tract infections, including pneumonia. This looks like a long list, but it's going to be very simple and easy. I'm going to break it down. We will discuss the drugs to treat influenza, COVID-19, pharyngitis, otitis media, rhinosinusitis, and pneumonia. Pneumonia is the major topic here, super important. We will cover drugs for community acquired pneumonia, hospital acquired pneumonia, ventilator acquired pneumonia, and aspiration pneumonia. Then also in community acquired pneumonia or CAP, we will cover typical and atypical treatment pathogens, and also in atypical we are going to discuss about walking pneumonia also. Specifically the nasty pathogens we are going to target when we treat pneumonia are MRSA, Klebsiella, and Pseudomonas. These are very super important pathogens because patients can die if you leave it untreated. Okay, so another point to remember, in this section there are 3 drugs I'm going to give you with a combination, and the second part I didn't highlight as a drug in blue color. Reason, this will not kill the pathogen, but it's going to boost or somehow supply the additional antibacterial or antiviral effect of the combination drug. So we're going to discuss that 3 points, specifically Nirmatrelvir-ritonavir combination, Amoxicillin-clavulanate, and Imipenem-cilastatin. Okay, let's focus on the first section here. Influenza starts with the single drug. There are 4 FDA approved drugs there, but one drug, this one is super easy to remember and understand because this is a commonly prescribed one for both prophylaxis and for treatment. Okay, mechanism of action, this drug actually inhibit neuraminidase enzyme of the virus, so that the viral virions will be prevented from leaving the infected cells. It will be blocking the spreading the infection. Another important point to remember, this drug must be given within 24 to 48 hours of the infection. So this is for a viral infection. Remember, influenza is a contagious disease caused by virus, so we can use this Oseltamivir for treating as prophylaxis or for as a treatment. Okay, another point to remember, this drug can cause insomnia. Other than that, it's like mild symptoms, especially in nursing home or a big community, and if you have to protect patients from specifically elderly patients or immunocompromised patients, you can give this. If one person got flu, you don't want to spread that to the community in that group, therefore you can give this as a prophylactic therapy also. Okay, so neuraminidase inhibitor, that's a mechanism of action and indication are super important for that drug. Drug name is important. Next drug name is a combination drug, 2023 approved FDA approved drug for COVID-19. Okay, before that I missed to mention one thing. For influenza, amantadine used to give to the patients, but keep in mind now FDA is not recommending that drug for especially the prophylaxis or treatment of influenza or flu. Reason, that drug can cause a lot of resistance. Okay, because that drug can block the matrix protein M2 ion channel, but M2 ion channel can always mutate, so the virus become very tricky, so that amantadine, that drug will not work in most of the patients. Therefore oseltamivir is better, and also oseltamivir is effective for both influenza A and B. When you compare, amantadine is effective only for A, it will not cover B. Okay, influenza B. So that's another point. Okay, COVID-19, this Nirmatrelvir is a super drug. This will kill COVID-19 virus. But the problem here is, as soon as it gets into the body, this drug can be deactivated by our liver CYP enzyme, CYP3A4 enzyme. Therefore, the patient who have this COVID-19 virus will not get enough drug into their plasma throughout that maybe next 12 to 24 hours. You need to make sure to keep a sustained level of drug in the blood. Then only you can kill the pathogen and reduce that infection can be controlled. So to do that, we can block the CYP enzyme. CYP3A4 enzyme is the one chopping down this Nirmatrelvir. Therefore, smart scientists found out a drug which combined, that is called ritonavir. If you really ask me what is the mechanism, easy. Both of these are protease inhibitors, okay, viral protease inhibitor. How do you distinguish? Nirmatrelvir is the only drug which inhibiting or blocking the protease enzyme of the COVID-19 virus. But ritonavir is a protease inhibitor of the HIV virus. It is nothing to do with the COVID-19 because ritonavir cannot kill COVID-19 particles. But why do you combine? Reason, ritonavir, in addition to that HIV viral protease inhibition, this drug can easily bind to the heme group of our CYP3A4 enzyme. It will be a very covalent binding. Therefore, you can guarantee that CYP3A4 enzymes are blocked. Therefore, the patient's bloodstream will have Nirmatrelvir for longer time. That is the reason this drug is very effective. This drug combination is very effective to treat COVID-19. Hope you understood that basic point. That is super important. Understand Nirmatrelvir actually a protease inhibitor. In case if you wanted to know the protease name, it is actually called MPRO. That means main protease of the COVID-19 can be blocked by Nirmatrelvir. That's MPRO inhibitor is of COVID-19 is Nirmatrelvir. Nirmatrelvir is protected from the chopping down of our liver hepatic CYP3 enzymes by the use of ritonavir. Therefore, this drug combination is working perfectly well. Okay, so another point, if you wanted to remember, its adverse effect is Nirmatrelvir can influence or activate one of our taste receptors, that is a bitter taste receptor. It is called a TAS2R1. You don't have to memorize, but one of the bitter receptor will be activating. Therefore, there will be a taste different, metallic taste in your mouth. But since ritonavir can increase the availability of Nirmatrelvir in the bloodstream, prolong the activity of Nirmatrelvir, adding this combination can cause more metallic taste. That's one point to remember. Then pharyngitis, easy. I remember PP. Pharyngitis, the go-to drug is Penicillin VK. Okay, so that is a very unique point to remember. The reason is generally 80% of the pharyngitis is due to the viral infection. But that whenever the patient get pharyngitis, if it is bacterial, that will be strep throat, right? Strep pharyngitis. Strep pyogenes is the pathogen. Penicillin VK can easily get in and chop all the strep pyogen bacteria. That is the reason Penicillin V is the drug of choice for pharyngitis. Okay, in case if there is a recurrent infection, you can go for Amoxicillin-clavulanate in the patient. But otherwise, no evidence proving that any other drugs are best or better than Penicillin VK. Therefore, pharyngitis you can treat with the Penicillin VK. Okay, you know the mechanism of action is cell wall synthesis inhibitor. general penicillin mechanism of action, adverse effect, etc. Okay, anaphylactic shock is a severe adverse effect, and it can sometimes irritate the belly. Those are the points to remember. Otherwise, it's a well-tolerated drug, even very good for children and pregnant female, okay, and the elderly. The next drug is otitis media and sinusitis. Okay, remember otitis media common in children, right? Because of their ear canals are very short, so bacteria can easily get into the system. That is the reason children's get, once they get grown, they get enough length so that bacteria infection will be reducing. You know the reasons. But anyway, these two conditions, you can remember only one indication. Drugs, amoxicillin is the ghost or first choice go-to drug for treating otitis media or sinusitis. Very strong drug with a very good coverage. It can kill most of the pathogen. But if the patient already took the drug, or like if the patient getting this recurrent, like every year, multiple times the patient getting the infection, reason some of the bacteria is still surviving, they are resistant to the amoxicillin. Reason the pathogens or the bacteria started producing a lot of beta-lactamase. To prevent that, to kill those beta-lactamase producing bacteria, you can add clavulanate into that. So let's talk about that. Amoxicillin-clavulanate. So this is the same drug combination when you first study first basic things when you study the community acquired pneumonia. This is the first thing, like you can prescribe amoxicillin, and if there is a recurrent condition, you can, or suspected beta-lactamase, you can prescribe clavulanate combined with the amoxicillin. So let's talk about that. These two drugs, mechanism of action similar to penicillin. This is going to bind and block penicillin binding proteins so that it will be cell wall synthesis inhibition. And another important point, adverse effects. You have to learn two major adverse effects. Amoxicillin and amoxicillin-clavulanate, penicillins, all these have a common adverse effect, specifically in amoxicillin in children, right? They can cause macular-papillary rash, but once you stop the drug, it will be removed from the system. The macular-papillary rash will be disappearing. Okay, even if the patient has that one time, still you can prescribe this drug again. Nothing to worry about. It's not that complicated. But amoxicillin has a serious adverse effect. Remember, it will be IgE mediated anaphylactic shock. That is super serious. Like, it's very rare, but it is very important to remember. Also, keep in mind, anaphylactic shock will be within few minutes or hours. It will be happening. But the common adverse effect, macular-papillary rash, that is IgG mediated, and it will happening like couple of days later. Okay. And amoxicillin-clavulanate have same mechanism adverse effects, but one thing to remember, it has an additional adverse effect because of the adding of clavulanate or clavulanic acid. Reason, clavulanate or clavulanic acid will not absorb directly into the everything, like all drug will not be absorbed into the bloodstream. The leftover clavulanate move to our colon, and they can kill some of the pathogens. It will increase the anaerobic and other pathogens to bacteria to survive. But the some of the good bacteria can be killed. Also, clavulanate metabolite, acidic metabolite, cause irritation to your colon. That's why some patients get about 10% higher risk of diarrhea compared to treating with amoxicillin. That's a very small fraction. But keep in mind, clavulanate combining with amoxicillin to prevent beta-lactamase activity. Okay, so that's another point. Why do you add clavulanate? Clavulanate cannot kill bacteria. That's an important point to remember. You cannot treat bacterial disease with clavulanate or clavulanic acid. But instead, when you combine clavulanate with amoxicillin or the drugs, because it has the same unique pharmacokinetics and structural uniqueness, what do? when the bacteria produce this beta-lactamase, clavulanate bind with the beta-lactamase and inactivate it, so that amoxicillin can liberate from that and drug and go and kill the pathogen. Okay, so clavulanate bind the beta-lactamase and inactivate it so that amoxicillin can work well. Okay, that's it. So let's move on. The same mechanisms we will learn in for the pneumonia cap also. So pneumonia I divided into, to make it easy, divided into cap, HAP, etc. But let's discuss the cap or community acquired pneumonia. Okay, one basic thing to remember, this is the basic step starting from zero. Pneumonia patient, most of the time you will be prescribing outpatients whenever the patient coming with a community acquired pneumonia. It is treatable, like a very well tolerated drugs are there. You can guarantee that you can kill it. But the problem, there are exceptions of course, and also there may be exception, like there are serious MRSA or Pseudomonas. We will talk about that. But generally, when you prescribe, we're gonna learn about 6 different types of patients we can treat for community acquired pneumonia. So let's talk about that from the basic step. Okay, there are 2 types of pathogens: atypical bacteria or typical bacteria. So remember, atypical does not have a cell wall. Therefore, if you are using a cell wall synthesis inhibitor, the patient will be still sick. You cannot treat pneumonia by using cell wall synthesis. That is the reason penicillins and those kind of drugs will not work. Keep in mind, okay? Easy to understand. So, atypical we are going to discuss in few minutes, but let's start with the typical, okay? So, typical pneumonia, community acquired. Okay, suppose mostly patients get a healthy patient under 40 years of age. You can easily give amoxicillin, very well tolerated drug, and it can easily kill the pathogen, and the patient will be cured without any problem. So that's why that drug amoxicillin, that is for the first condition, okay, community acute strep pneumonia will be treated. What if a patient with a recent antibiotic history? Keep in mind, if a patient has a recent antibiotic history, there is a chance for beta-lactamase, because there are, even though the bacteria doesn't have a brain, they are very tricky and smart. They can produce beta-lactamase. So to cover that, you can add, instead of amoxicillin, you can prescribe amoxicillin-clavulanate. And keep in mind, amoxicillin-clavulanate will protect. You can guarantee, give an additional coverage that, the patient will be cured without any, you don't have to. Anyway, so the next one, what is in the next condition? Same mechanism, adverse effect, all those, okay? But the next condition, what if a patient has comorbidities? For instance, what if the patient is not patient is okay, healthy and all, but what if the patient has type 2 diabetics, heart problem, hypertension, renal or kidney problems, renal or hepatic problems and all, and they are taking other drugs. In that condition, we have to make sure to cover additional pathogens also. That is the reason FDA indicated a monotherapy. You just need one drug, right? That is a respiratory fluoroquinolone. Super important to distinguish that. The reason is you don't want to take any risk. Also to cover, even though typical bacteria is covering this, community acquired pneumonia, still to as a safe side, you can give levofloxacin. Of course, when sick patients, you can give levofloxacin. Levofloxacin can cover gram-negative, gram-positive, and also some of the atypical bacteria also. Even some level of Pseudomonas coverage also there. That is the reason you can give as a monotherapy and let the patient go home, or even in the hospital setting. Keep in mind, this is generally outpatient. Very good. All the 3 oral drugs. Let's move on to the atypical. Atypical community acquired pneumonia. Let's talk about walking pneumonia first. Easy to remember. These pathogens are not of course, they can cause pneumonia, but the patient is not really seriously sick, or they literally walk into your clinic and say, when you had mentioned, when you check that, like, okay, pneumonia, but the patient is really not like that seriously ill. That's why the term walking pneumonia comes. Generally, walking pneumonia caused by mycoplasma. Keep in mind what is the difference between the typical and atypical. This atypical mycoplasma, they do not have a cell wall. Therefore, you need unique drugs which pass to the getting into the bacteria and chop the protein synthesis machinery or 50S ribosome. That is why we are taking the primary drug azithromycin. Always remember, old days or some of the elderly physicians, they still prescribe azithromycin to other typical pneumonia. Now CDC mentioned that no, the other pneumonia conditions, you are not going to add azithromycin or not a primary monotherapy for any other pneumonia other than atypical pneumonia. Reason, azithromycin causes about more than 25% of resistant, according to based on 2025 review from CDC and American Thoracic Society, all these recommendations, right? When you look at it, you can see that. So therefore, azithromycin when to use in pneumonia? Only when that is really recommended, only when the patient is healthy and known or suspected atypical, specifically mycoplasma and these unique pathogens, atypical pneumonia. Okay, azithromycin. What if this pathogen is not you are suspecting mycoplasma and maybe a group of like other atypical bacteria. For instance, that is called a double coverage. If you need additional coverage, you need little more broad spectrum drug. That is why the go-to drug is actually doxycycline. Okay, so keep in mind why doxycycline and also you must add doxycycline plus Amoxicillin-clavulanate, right? Because that means that it is typical, but they maybe after you prescribe azithromycin, the patient is not cured. That's the time you can make sure to add doxycycline and amoxicillin-clavulanate. That's a combination. Okay, so keep in mind. And what if a patient is hospitalized with a community acquired pneumonia? In that case, you have IV drug, ceftriaxone, and to cover that atypical pathogens, you can give azithromycin. So IV drugs are there. So ceftriaxone, remember, that is a third generation cephalosporin. Okay, stop right there. I forgot to mention the azithromycin. I think you already know, but still, because there is another lecture summary is available in the channel about antibiotics summary. In that I gave you all the details, but still, if you wanted to remember, the azithromycin is the Z pack. It has a very long half-life, so daily drug is you can prescribe daily drug. Once daily drug is available. Then this is mechanism of action is protein synthesis inhibitor, similar to doxycycline, also protein synthesis inhibitor. But what is the difference? Azithromycin is a macrolide. Doxycycline is a tetracycline. Azithromycin is a 50S ribosome inhibitor in protein synthesis inhibition, but doxycycline is a 30S ribosome inhibition. Okay, that's also a protein synthesis inhibition. That is the difference. Okay. Then azithromycin adverse effect, it can cause a QT prolongation. Okay, but other than that, it is a well tolerated drug, very gentle to the body, and even good for pregnancy and elderly, and also if a patient has a beta-lactam allergy, this drug is good. But the only problem is it might not cover the other pathogen because of the resistance. It can be high risk of resistance. Doxycycline, what are the major points to remember? Usually combined with, not individual. I forgot to add that amoxicillin-clavulanate, usually given with, if multiple pathogens suspected, you give with the amoxicillin-clavulanate and doxycycline. Okay, doxycycline, like I said, tetracycline, protein synthesis inhibitor. Difference from azithromycin, this is a 30S ribosome inhibitor. Adverse effects are important. Phototoxicity, because doxycycline molecules can deposit in your cell, like keratinocytes in the skin, and especially when you expose to sunlight, UV light will break that into, activate into halogenated compound and cause skin irritation. That's called phototoxicity. Then gastric discomfort can be given to, and also this is like a broad spectrum, right? It can kill a lot of good bacteria also. And chelation with a calcium. For instance, if a patient is taking with a milk or any calcium containing multivitamins or something, the drug will not absorb into the blood. The patient will be still sick. Reason, the drug will be staying in the belly instead of absorbing into the blood. That's a super important advice you have to give to the patient. Okay, and that's it. Like it is contraindicated in children and pregnancy because it can affect the bone and cartilage growth in the developing fetus. Okay, and then hospital. Okay, so let's stop right there. I forgot to explain the levofloxacin adverse effect earlier. Levofloxacin also, remember that has a very it's contraindicated in children and pregnancy. That's like a really patients under 18 contraindication. Reason, levofloxacin, that's a fluorine contained drug. This can easily deposit into the chondrocytes and like a bones, like osteocytes and fibroblast cells. Especially it will be affecting your tendons and Achilles tendon rupture, like your specifically your Achilles tendon, we discussed that, aortic rupture, aneurysm, etc. Right? Like those are the major things to remember. And why is it contraindicated in children and even adult? You have to be very careful about giving this drug. Also, if a patient has QT prolongation, don't give this drug. Okay. Anyway, let's move on. So ceftriaxone, why I stopped right there is ceftriaxone has it's a third generation cephalosporin. This drug is an IV drug. You should not combine IV calcium with this route along with the IV ceftriaxone. Reason, calcium can deposit ceftriaxone, which can accumulate into, these deposits can accumulate into patient's lung, liver, etc. For instance, especially in neonates and elderly. That is the reason, for the board point of view and the clinical practice, you have to remember that point. Ceftriaxone, because in hospital setting, that's a commonly used drug. Okay, very strong, very effective drug. Ceftriaxone can precipitate into the lung if you combine with the IV calcium. Therefore, you should not co-administrate. What is the difference of doxycycline and levofloxacin calcium story? Doxycycline and levofloxacin oral drugs, these drugs can chelate with the calcium, right? That is the reason when you when a patient takes doxycycline or levofloxacin, try to avoid that calcium carbonate, or like a antacid, calcium multivitamins, etc. along with that. But this one is IV ceftriaxone with IV calcium co-administration is contraindicated. Keep in mind, okay? Then I think that's a mechanism of action, cell wall synthesis inhibition. That's a cephalosporin. Okay. The next one, community acquired pneumonia. The patient is hospitalized with a beta-lactam allergy. If the patient also has a suspected pseudomonas, that's a gram-negative, right? There is a drug that is a beta-lactam which can easily pass into the gram-negative bacteria. It cannot kill gram-positive. It cannot get into the gram-positive bacteria. Therefore, it is very unique. Aerobic bacteria, gram-negative bacteria, specifically targeted by Aztreonam. Aztreonam is a very super drug. It is actually reserved for hospital, like a very serious illness, right? You need to have like a special permission from infectious disease wing to prescribe this drug. Reason, it is a very effective drug, it can cause a super infection and all if you give to the patients, because this is a strong drug, can kill a lot of gram-negative bacteria and it can cause super infection. That is the reason it has to be very careful when to prescribe this drug. If a patient has community acquired or even hospital acquired or ventilator acquired pneumonia, any type of pneumonia, and if the patient is severely ill, hospitalized with a beta-lactam allergy, that means you cannot give any other beta-lactam, ceftriaxone, you cannot give, right? So in that case, you can consider this drug. Of course, we have other choices, but we will talk about, even if you have to think about, like if you have Pseudomonas coverage you need it, Aztreonam is a go-to drug. Okay, mechanism of action, easy. This is a cell wall synthesis inhibitor, but adverse effect is actually super infection, risk of super infection is the point. Okay, the next is all the section like put it together: hospital acquired, ventilator acquired, like aspiration acquired, or community acquired severely ill conditions, right? All these conditions, when you talk about, there may be specific pathogen, MRSA. So that's a super important point. Like board like to ask that questions, right? How do you kill MRSA, especially the patients with any of the pneumonia, and if you are suspected or if there is MRSA in it, methicillin-resistant Staph aureus, you need to pick the specific drug to kill the pathogens, right? Especially if a patient has MRSA or Klebsiella or Pseudomonas, you need to pick or add the specific drug which targeting that pathogens, so that you will make sure the patient is cured. So therefore, MRSA, there are two drugs I want you to remember. One oral drug, it can give inpatient or outpatient, that is linezolid. But vancomycin, oh, not oral. That's a $1 million question, right? $1 million question drug. Reason, vancomycin oral is only to treat C. diarrhea, C. diff diarrhea, right? C. diff clostridioids difficile causing diarrhea. The reason, vancomycin oral is a large molecule. It cannot absorb into the blood. It will stay in the digestive system and go to the colon and kill all the clostridial C. diff pathogens. But vancomycin oral, if you given to any systemic infection, pneumonia or any other diseases, it will not absorb into the blood. Very less than 5%, it is not effective. Therefore, you must give as IV. So always you can even write here. This is IV vancomycin. IV vancomycin is the drug to treat MRSA anytime. Any patient, any condition. If a patient has a MRSA, suspected MRSA, you always think that it must be an IV vancomycin. That's it. Then, linezolid was the drug we always used as a backup. We're going to keep it at a side even in the first year when we learned the antibiotics. But why do we need this as a primary drug? Now I am teaching this is an oral drug. You can trust this drug and giving to outpatient if a patient has to be given. You are not going to give like a very mild coverage. Like remember clindamycin. Some drugs have little bit MRSA coverage. No. That's not enough. For pneumonia, you need that strong like efficacy. And also linezolid has another point. It has an ability for multi-drug resistant infections causing pathogens can be killed by this drug. That's very good. You can trust that this is going to kill the pathogen. Therefore, linezolid is very effective oral outpatient drug for MRSA coverage in pneumonia. Okay? Anytime, like usually hospital acquired, all those conditions. Anyway, hope I explain everything. Linezolid adverse effect, one point to remember is bone marrow suppression is very common, and also it can cause serotonin syndrome. Therefore, if a patient already has an antidepressant or a SSRI already taking, that can lead to life-threatening adverse outcome. Maybe you have to remember that for the board exam. Reason, if a patient has SSRI in the taking, it can lead to life-threatening serotonin syndrome. Okay, that's a big thing to remember. And also bone marrow suppression is common with it. These are the reason. If you have to save the life of a patient, this is a good drug, right? The patient is very sick with the pneumonia. Yeah, you need to save the patient's life. That's why I remember like last resort drug. So, but that means it's an oral trustworthy drug for MRSA. Suspected MRSA or pneumonia caused by MRSA, methicillin resistant staph aureus. Very good. And vancomycin, what are the 2-3 things? And linezolid, if you remember, that's also super important to remember. That is a protein synthesis inhibitor. Okay, it is a 50S ribosome inhibitor drug. And vancomycin, that is a cell wall synthesis inhibitor. Remember, it is entirely different than beta-lactam. It doesn't have a beta-lactam ring. This is a huge molecule. This is going to be like a binding and blocking in a different way. You can refer in other videos. But since I'm trying to finish it in one hour. I don't want to explain too much, but understand that it is available in the channel in other videos, but look at it. Vancomycin, cell wall synthesis inhibitor. It can cover MRSA, very good, and it has adverse effects. Those are important to remember, and a drug interaction. Those are super important reason. It can cause common adverse effect and like a severe adverse effect. So let's talk about common, right? Most of the patients, if you are like a infusion reaction, because this is a toxic agent, right? Body don't like it. So therefore, vancomycin directly degranulate or stimulate mast cells and basophils to degranulate. This will cause the erythema, rash on face and upper torso, all these areas. This is called infusion reaction specific to vancomycin. That is, old days we used to call that name Redman syndrome. Now, commonly accepted term is vancomycin flushing syndrome. What is the reason? It is not like immunity associated reaction. It is just a non-allergic infusion reaction. Okay, understand that. But that is common in patient. If you have to do slow infusion with some precaution, you can avoid that. But what if there is a patient patients can develop severe adverse effect? Let's talk about that. 2 adverse effects, nephrotoxicity and ototoxicity associated with remember, this drug can accumulate into the proximal convoluted tubule of your nephron and kill the proximal convoluted cells. That means you are losing the kidney. That's not good. So keep in mind, it's a life-saving drug. But if you that's why you don't use this drug for every simple diseases, right? When it is very necessary, the patient is hospitalized and is very sick and MRSA, that's a time we are going to pick this drug. Anyway, understand this can lead to irreversible adversible, but commonly as soon as you stop it, that that drug molecules will be eliminated from your proximal convoluted tubule, so that you can save nephron at some point, at some level, right? But one problem, when it accumulates in your cochlear cells, it's going to damage your hearing, tinnitus to auditory dysfunction. This will be permanent. It can become an irreversible adverse effect. Therefore, I want you to remember both seriously. Nephrotoxicity and ototoxicity. Another drug in another class, aminoglycosides, right? Those drugs can cause ototoxicity and nephrotoxicity. Therefore, you should never combine vancomycin with aminoglycosides. That's all. Then Klebsiella. Okay, that is a unique pathogen. That's a rare one, but Klebsiella, atypical condition. But this pathogen can develop extended spectrum beta-lactamase. The problem is, this is very notorious to produce extended spectrum beta-lactamase. Therefore, no other drugs will work. You need to specifically target that pathogen with a unique drug called Imipenem. or there is a modern drug available that is called Meropenem. Imipenem and Meropenem can kill, but commonly used one is Imipenem. Imipenem-cilastatin, why is it combined with another drug? Let's talk about that, right? Okay, Imipenem can kill Klebsiella pneumonia. That pathogen Klebsiella can be killed by that. And even it is very effective for, it's like a seriously ill patient only receive this Imipenem, okay? Like not like a outpatient drug. It is like a IV. So it can penetrate blood-brain barrier and indicated when even in the neutropenic patient, it is very effective. Mechanism of action, this is actually binding and blocking the penicillin binding protein and cell wall synthesis inhibitor. But how do you distinguish beta-lactam with other beta-lactams with the Imipenem? Because this drug will be acetylating the penicillin binding protein. Imipenem will work well, but the problem is it will be eliminated through the glomerular filtration and through the kidney very fast. And also Imipenem can deposit in your nephrons. How do you prevent that? By adding cilastatin. Let's talk about that story, right? So cilastatin is a chemical that is not the drug to kill Klebsiella bacteria. No, it cannot alone kill the bacteria. Bacteria can be killed by Imipenem drug. But the problem is in the body, patient's body, Imipenem eliminated very fast. You need to keep sustained blood level of Imipenem so that the patient will be cured. You don't want pneumonial causing pathogens. Even the Pseudomonas coverage is there. Somewhere I put it. Meropenem and Imipenem has Pseudomonas coverage. So this Pseudomonas or Klebsiella pathogen can multiply after a couple of hours. So you need prolonged sustained level of Imipenem in the patient's blood. So what do? Cilastatin is a compound. Whenever you combine cilastatin, in the presence of cilastatin, organic anion transporters in your nephrons will busy eliminating cilastatin so that Imipenem will be staying in the blood for longer time. One more point if you like to know, Imipenem metabolized very fast too. That's also with the help of renal. There are some enzymes called dihydropeptidase 1. So in the nephron, Imipenem metabolized into inactivate into metabolites and removed. That metabolite actually become it's actually a toxic metabolite, right? So that's also deposit in the kidney. So Imipenem drug's effect is gone very quick. So cilastatin has a double role actually. First role, it will stop the elimination of Imipenem. Instead, cilastatin, as soon as the body sees cilastatin, they will try to get rid of cilastatin first. By that time, Imipenem can stay longer. Second function, cilastatin also block the conversion of Imipenem or metabolism of Imipenem so that nephrotoxic agent will not be forming. If you are really confused, just remember Imipenem's activity can be keeping for longer time with the help of cilastatin. That's an important point to remember. Next one, Pseudomonas coverage, and last topic in this one. In any type of pneumonia, including community acute pneumonia, if you have Pseudomonas, suspected Pseudomonas, you can use these drugs, right? So the major drug, how I remember, is Pime and Dime for Pseudo. So Pime and Dime. So Cefepime and Ceftazidime, those are for Pseudomonas coverage, okay? So another thing for the Piperacillin-tazobactam, that's effective. Oh, I forgot to mention. Pseudomonas coverage, typically you can use beta-lactam antibiotics. That means, look at it. Aztreonam is a beta-lactam antibiotic. Cefepime, Ceftazidime, those are beta-lactam. Those are cephalosporins. Piperacillin-tazobactam, that is a combination like the clavulanate, right? Piperacillin can be broken down by beta-lactamase. To prevent that, you are adding tazobactam. So piperacillin is a penicillin, okay? That's also a beta-lactam antibiotic. See, Aztreonam and Meropenem, Imipenem-cilastatin, all those are beta-lactam. So that means Pseudomonas can be killed by beta-lactam antibiotics. Very good. So major ones, Ceftazidime and Cefapime. These are 4th generation and 3rd generation cephalosporin, effective for that. And also in sometimes you will go, especially in the hospital, right, they will just use Piperacillin-tazobactam. That will be effective too. So remember 3-4 drug, especially the beta-lactam, if a patient, even though Aztreonam, that's a difference, right? Even though Aztreonam is a beta-lactam antibiotic, this drug will not interact with any other beta-lactam rings. That is why if a patient has beta-lactam allergy, that is a super important point to remember in a clinical sense, important in the point. Aztreonam is very effective to treat even in the patient with a beta-lactam allergy. If you cannot pick any of the other drugs, you can go for Aztreonam, right? Of course, but if the patient has beta-lactam allergy, you cannot pick Piperacillin-tazobactam, Cefapime, Ceftazidime, anything. So this will be effective for Pseudomonas coverage. Then Cefapime, Ceftazidime, what are the major things to remember in this one? So all those, like Cefapime is a Pseudomonas coverage. Usually ventilator associated pneumonia can, like one of the reason with this pneumonia may be because of the Pseudomonas. That time the go-to drug is Cefapime. How do you remember why? How effective compared to all other drugs? Cefapime is very unique and effective. Reason this drug can, it is a sweater ion. That's why it can rapidly penetrate into the gram-negative cells, specifically the Pseudomonas, right? So this is a very effective even for immunocompromised patients and even in pregnancy. Okay, so it can pass blood-brain barrier. All those points to remember. And what else? And Ceftazidime is a 3rd generation cephalosporin, but this is a nothing much to remember. Even in HAP, VAP or CA, CAP, any type of Pseudomonas, these drugs can be effective, either of these drugs. Okay, Piperacillin-tazobactam, Piperacillin, typical penicillin points, but add the tazobactam as a similar to clavulanate. That means it will bind and inactivate the beta-lactamase enzyme. And the Aztreonam we already discussed, that will be specific for gram-negative bacteria, right? Pseudomonas coverage is there for beta-lactam allergy. Keep in mind, these are super drug for hospital settings. Only linezolid is the outpatient because it is an oral drug available, but all the other drugs are IV drugs in the hospital setting you are using, right? Strong drugs. And another thing, why is it preserved for only, these are for life saving, because this can cause super infection because it can chop down most of the bacteria in the body, right? So like I said, Pseudomonas coverage, Imipenem-cilastatin also has that, and also Meropenem, that's a new drug. Meropenem also has that. And the last point I didn't include in this section, that is aspiration pneumonia. Keep in mind, aspiration pneumonia, what is the thing to remember is, think of anaerobes and enterics, because that's how it's aspire into the lungs and you're going to get that infection. Usually the go-to drug is beta-lactam drugs with the beta-lactamase inhibitor, right? Even you can use Ampicillin-sulbactam. I don't have space in the slide, that's why I didn't include. Ampicillin-sulbactam can be very effective in the patients with a community acquired aspiration pneumonia or hospital acquired aspiration pneumonia, or sometimes you can give Vancomycin and Piperacillin-tazobactam. Okay, so these are the major point. Hope I didn't miss anything, and I thought I missed something in my brain. Yeah, fungal and any other type of pneumonia, especially fungal pneumonia. There is a summary in the another in this section. You can look at in the channel. There I am discussing fungal drugs. In there I am talking about pneumonia caused by fungus treated by certain drugs. So that will be antifungal drugs, right? So here we are covering only the bacterial drug for pneumonia, because that's a commonly common cause for pneumonia, right? I think, yeah, there is another section called TB, tuberculosis mycobacteria drug. I'm going to release in the next video. Okay, hopefully I get time. Let's see, and hope this helps, and this will be very effective and useful for your board review, board exam, because this is super important for pneumonia. Drugs are super important, especially present day. COVID-19 and flu, influenza drugs are also important for board exam point of view. Specifically target MRSA, Klebsiella, Pseudomonas coverage also, all those. Okay, thank you. Bye.